Hi guys, this is Taylor, and I'm going to spend the next few minutes walking y'all through some of the vasculature of the abdomen. All right, so let's get our noggins thinking for a minute. We're going to start off with a case study. All right, so we have our image right here, and then I'm just going to read the patient's history. So an elderly woman presents to the emergency department complaining of severe back pain. The patient has a history of high blood pressure and cigarette smoking. On physical examination, a large pulsatile midline abdominal mass is palpated. During the course of the examination, the patient suddenly becomes hypotensive and goes into cardiac arrest, at which time her abdomen begins to swell. A stat bedside sonogram shows the images to the right and free fluid in the abdomen. What is the most likely diagnosis? So y'all think on this while we go through this presentation, and then the results will be at the end. All right, so first we're going to start with our abdominal aorta. A little bit of review for the aorta is it's the largest artery in the body. It has 5 sections, so we have the root of the aorta, the ascending aorta, and the aortic arch. The descending aorta, which is also known as the thoracic aorta, the abdominal aorta and its branches, and then the bifurcation into the iliac arteries. The aorta enters the abdomen posteriorly and courses anteriorly as it progresses caudally. It is retroperitoneal and lies to the patient's left side, and it's also posterior to the pancreas. So why do we image the aorta? The main reason that we image the aorta is to screen for aneurysms or to monitor pre-existing aneurysms to make sure they aren't growing super rapid. So for our aortic exam, a couple of reasons for the exam would be a pulsatile abdominal mass, abdominal pain, back pain, a drop in hematocrit, which usually means it's ruptured, swelling of the lower extremities, or a family history of AAA. Some risk factors of a AAA would be tobacco use, so think smoking, being of the male gender, atherosclerosis, hypertension, vascular disease, or a pre-existing vascular disease, COPD, and or a family history of abdominal aortic aneurysms. There can be one of these things, it can be a multiple of these things. Usually the registry will ask you a combination of these things, so they might say something like a AAA screening would be recommended in an individual who is what? Usually the answer choice is male that smoked and then usually has a family history of AAA. The most common cause of AAA is atherosclerosis. However, this is theorized and not necessarily clinically proven. So now we're going to go into aneurysms. So an abdominal aortic aneurysm is defined as a vessel diameter of greater than 3 centimeters or noted focal dilation of at least 50% of the normal diameter. They're mostly common and potentially fatal, or they're a potentially fatal condition that is seen generally in older patients. Sonography is the preferred method to eval and screen for aneurysms. When it's ruptured, that's a whole different story, but just to eval aneurysms and screen for them, usually in an outpatient setting, sonography is preferred. There are limitations including obesity, prior abdominal surgery, and overlying bowel gas. Risk factors, think back to those risk factors. Those are going to be on the registry, so the quicker you learn them, the better. Again, those risk factors would be male gender, pre-existing vascular disease, tobacco use, such as smoking, things like that. The clinical findings of an aneurysm are usually none. They're pretty asymptomatic. If they do present, usually it presents as some sort of back, abdominal, or leg pain. So here we have our little aneurysm. This anechoic part is our aorta, and then this kind of hypoechoic larger part is the actual aneurysm. So again, here we have our abdominal aortic aneurysm. Here is our aorta, and then this is the aneurysm around. Again, aorta, in our sagittal view, and then this is the aneurysm around. If an aneurysm is seen, it should be followed to measure the length of the dilation and to note the position of the renal arteries in relationship to that aneurysm. So here we have our normal aorta, and then here we have our focal outpouching of that aneurysm, and then we can see it lies just inferior to those renal arteries here. If you are scanning an aneurysm and you're having a hard time finding the renal arteries, you can put color Doppler on to help. And then once you have these images taken, you're going to want to measure once in the sagittal plane and then twice in the transverse plane. There are a few features of a AAA. A big registry question is this right here. So 85% of all AAAs are infrarenal, which just means they're inferior to the renal arteries, and they occur in the distal aorta. The abdominal aortic aneurysms are more common, or abdominal aortic aneurysms are more common than, say, a thoracic aneurysm. And then our mural thrombus is common with larger aneurysms. So here we have a picture of our aortic aneurysm, and then this material right here is the thrombus inside of that aneurysm. We'll go into this in detail a little bit later, but just to get y'all thinking, some symptoms of a rupture include excruciating abdominal pain, shock, and expanding abdominal mass. Sometimes if a patient has a pre-existing aneurysm somewhere in the aorta, they can have an iliac or a popliteal artery aneurysm as well. So y'all have already been over the types of aneurysms, so I'm just going to ask y'all some questions, and then y'all can pause the video and try and answer them, or y'all can just answer them in your head. So just to start out, there's 3 types of aneurysms: true, false, and dissecting. So which one of these involves all 3 layers? So if you guessed true, you are correct. Which one is going to have a true lumen and a false lumen? That's going to be our dissecting, and then we'll see an echogenic intimal flap as well with the dissecting aneurysm. And then, which type of aneurysm is more likely to occur after a procedure? That's going to be our false aneurysm or our pseudoaneurysm. And then lastly, which has to-fro flow? Again, that will be our false aneurysm or our pseudoaneurysm. The next few slides are just going to be kind of a review for y'all, so y'all can refresh your memory on what exactly a true, false, and a dissecting aneurysm is. So here we have our true aneurysm. Usually they are fusiform or saccular. Here we have more of a fusiform aneurysm, so we have that symmetric enlargement. Whereas here we have more of just that focal outpouching. Here we have, again, our fusiform aneurysm, and then we also have a iliac artery aneurysm present as well. And then with aneurysms, they do usually have a genetic association, so think prior family history. Again, here's our true aneurysm. So here it is in our sagittal plane. So we have aorta here, aneurysm here. Here it is in our transverse plane. So aneurysm here, and then aorta is this anechoic structure here. All right, so going into our false aneurysm, these do not involve all 3 layers. So think of, whenever you think of a false aneurysm, think of our pseudoaneurysms. So those are usually caused by an injury to the vessel wall, and then blood is leaked out and contained within the retroperitoneal space or those surrounding soft tissues. Pseudoaneurysms are commonly associated with peripheral arteries, more specifically with angiographic punctures or surgical anastomosis. So think trauma to the vessel, maybe a needle stick, and that's what causes that pseudoaneurysm. And then again, so trauma is the most common cause. Treatments usually include surgical repair, compression, or thrombin injection. I remember on my registry, I had a picture of a pseudoaneurysm, and the question was something like, what's the most common treatment, or what's a common treatment to get rid of this structure. And it was a pseudoaneurysm, and so one of the answer choices was thrombin injection, and so that's what I went with. The sonographic findings of a false aneurysm or a pseudoaneurysm is going to be a vascular compartment connected to the main artery by a neck or a stalk. If you drop a pulse wave Doppler down into that neck or stalk, you're going to actually see a bidirectional waveform, which is also called to-fro flow. I'll show a picture on the next slide, but you definitely want to know what to-fro flow is and what it's associated with for the registry. So here we have just our typical pseudoaneurysm. So if we remember back to our true aneurysm, we had kind of that symmetrical outpouching, whereas for our pseudoaneurysm, we have just this little tiny neck that's connecting the aorta or the vessel to our pseudoaneurysm. So here are some types of images that could be on the registry. They may give you an image like this and ask you, what is this waveform called? Or what is the pathology associated with this waveform? And so the answer would be a pseudoaneurysm, and then the waveform would be a to-fro flow waveform. They may give you this image and try and trick you into thinking it's saccular because it doesn't have that super thin, long neck or stalk. It's more of a short, stocky neck. And so they may ask you, is this a saccular aneurysm or is this a false or pseudoaneurysm? And the answer would be pseudoaneurysm because it doesn't have that little focal outpouching. It's more of a neck and then your little aneurysm, if that makes sense. So here you can pause the video, and I just want y'all to kind of look at this image and try and figure out what's going on. All right, so hopefully y'all paused the video and then y'all took a few minutes to look at this image and really decipher what's going on. So if we look here, we have our femoral artery. So this is our main artery. This is the neck connecting our main artery to our pseudoaneurysm. So this is how blood is getting into our pseudoaneurysm. Here we have a sagittal view of the exact same thing. So we have our femoral artery here, the neck, and then our pseudoaneurysm here. And then here we just don't have color flow on that pseudoaneurysm, but this is our pseudoaneurysm, and then this is them Dopplering that femoral artery. So think about what could have caused this. Could have been a needle stick, it could have been some type of trauma to the vessel, but usually it's a needle stick or something like that that causes this little neck into our pseudoaneurysm. Next we have our dissecting aneurysm. So this is when a separation of the vessel wall occurs, when the force of blood pumping through the vessel actually splits those layers of the arterial wall. And then this allows blood to leak in between those two walls. So the intima develops a tear through which blood leaks into the media of the artery wall, which is also known as our false lumen. Sonographically, this is seen as an intimal flap, which will be a thin echogenic linear structure in the true lumen. Most commonly, a dissecting aneurysm occurs in the thoracic aorta at the aortic arch. If there is a dissecting aneurysm in the ascending aorta, the mortality rate is much higher. Dissecting aneurysms can also extend up into the carotid arteries, or if it's in the abdominal aorta, it can be in the femoral arteries as well. So here we have images of our dissecting aneurysm. Be sure you know these images in transverse and in sagittal. These are big registry test questions, and so they will most likely show you one of these images and point to our little intimal flap here and ask you, what is this structure? Or what is this structure most commonly associated with, which would be our dissecting aneurysm. And then here is just our intimal flap again. There's a couple causes of dissecting aneurysms. The main one that y'all need to know for registries is Marfan syndrome. Marfan syndrome is basically just a genetic disorder that affects the body's connective tissues. That could be a registry question too. So whenever you think of Marfan syndrome, think of it causing a dissecting aneurysm. Another cause is chronic hypertension, atherosclerosis, or cystic medial necrosis, which is just a disease of the large arteries where there is a degenerative breakdown of collagen, elastin, and the smooth muscle, which contributes to the weakening of that vessel wall over time or as the patient ages. Coarctation of the aorta is another cause of a dissecting aneurysm. And so with coarctation, it's actually narrowing of the aorta, which forces the heart to pump blood harder through that narrowed space. And when blood is pumped harder, it has a higher chance of pushing through that arterial wall and creating a dissecting aneurysm. A few other causes include congenital aortic valve anomalies, chest trauma, or pre-existing aortic aneurysms. In all honesty, I'm not positive that Stanford versus DeBakey dissecting aneurysms are going to be on your registry, but I want y'all to have that information just in case they are and y'all are familiar with it. So it's just good information to know, so we'll kind of briefly just go over it. So for Stanford dissecting aneurysms, we have type A and type B. Type A is just going to involve the ascending aorta, so just this little part here, right there. And then type B is not going to involve the ascending aorta at all, so it's going to be more descending aorta. And then DeBakey has 3 types. So type 1 is going to involve the entire aorta. Type 2 is going to involve just the ascending aorta. And then type 3 is going to just involve the descending aorta. Again, I don't know if this is going to be on the registries, but it wouldn't hurt to know this chart. So when a patient has a dissecting aneurysm, usually they're going to have a lot of pain. So that pain can be severe chest pain, neck pain, throat pain, abdomen or low back pain if that dissecting aneurysm is in the descending aorta. They can present with syncope, muscle weakness. Sometimes they can have labored breathing and then absent lower extremity pulses. So here we have our dissecting aneurysm again. Just we have that intimal flap, and then here it is in our sagittal plane, and then here's that intimal flap here. Again, make sure you know images like this because they will most likely be on the registry. So there are a few other types of aneurysms. A really commonly known one is a Berry aneurysm, and that's just a small saccular aneurysm commonly located in the cerebellum. This type of aneurysm is also associated with polycystic kidney disease. I've heard that it can be tested on the registry, so make sure you know where a Berry aneurysm is located and that it can be associated with polycystic kidney disease. A mycotic aneurysm is just an infected aneurysm. So this is actually a mycotic aneurysm here. And so looking at this picture, we can see that this patient has some cellulitis going on. He has some echogenic soft tissues, which indicate that he has some type of infection going on. If this was in the ED doctor may order a white blood cell count. And if you look at that in their chart, usually it would be elevated with an infection. And so a registry question could be something to the effect of your patient presents to the ED with arm pain, swelling, and redness. You do an arm Doppler exam and you see this at the radial artery. You notice the cellulitis, you notice the echogenic soft tissues. What is the most likely diagnosis? And then it would be a mycotic aneurysm. There's also an atherosclerotic aneurysm, which just is the weakening of the media in severe atherosclerosis or severe buildup of plaque. Again, this is just a little bit of a review for y'all. but I listed them out just so y'all could kind of refresh your memory. So aneurysms less than 4 centimeters in diameter, they're going to be followed every 6 months with an intervention if the patient becomes symptomatic. So think of those clinical findings. So they might have some abdomen pain, they might have shortness of breath, things like that. For aneurysms 4 to 5 centimeters in diameter, surgical intervention may be suggested. And then repair is indicated for aneurysms that are larger than 5.5 centimeters or growing at a rate of 0.6 to 0.8 centimeters per year. For aneurysms that are over that 5 centimeter mark, they have a 25% increase of rupture over a course of 8 years. If the aorta does rupture, it is a surgical emergency, so sono isn't the first line of defense for that. We move into CAT scan. If it's just normal screening, outpatient sono, it will be, sonography will be the more preferred exam. However, if they're presenting with hypotension, signs of a rupture, then it's CT. And then aneurysms that are larger than 5 centimeters and are documented at rapid rates of expansion have an increased risk for catastrophic rupture, and then a ruptured aorta has a 50% mortality rate. So again, ruptured aneurysms, high mortality rate. They usually present as a pulsatile abdominal mass, slightly above or at the level of the umbilicus, which is just your belly button. And then the patient will present with severe pain and hypotension. The patient may also present with shock, so they might have or be in an altered mental state. They might be confused, sleepy, or even have clammy skin. If you are doing an ultrasound and you do notice that the aorta is ruptured, some of your findings may be that the aneurysm is still present or relatively intact. There will be blood in the surrounding tissues or hemoperitoneum, and then there could be a peri-aortic hematoma. And then here we have just our normal aortic aneurysm. Can you all guess what type of aortic aneurysm that would be? To me, it looks like a true aneurysm. So we have that symmetric outpouching or that symmetric enlargement of our aneurysm, and then it's also infrarenal. So here we have our renal arteries and our aneurysm is located inferior to those. Here we can see that there's a little tear up here and that blood is starting to leak out into the abdomen. And then here would be more of our catastrophic rupture where there's this huge rip here and then a lot of blood into the abdomen. So here's actually a CAT scan of a ruptured aneurysm. So right here we have our proximal aorta, and then we have celiac axis coming off right here, our superior mesenteric artery coming off right here, and then we see as we get to mid-aorta, it's just kind of this huge mess. And so this is actually a ruptured aneurysm, and then we can see that we can't even see our distal aorta because of the rupture. This is just a little review chart to kind of refresh y'all's memory. Y'all can pause the video, look over it, but it's just a good study material to have for the registry, so I included it for you. All right, so next we're going to get into endovascular grafts and stents. I'm just going to briefly cover the basics of this. Miss Gray will actually cover this topic more in depth later on in the semester, so we're just going to do a real basic overview. So endovascular stent graft repairs are an alternative treatment to open abdominal surgery to fix an aortic aneurysm. They're more preferred because it's a decreased recovery time for the patient, and the morbidity and mortality rate is actually decreased. If the AAA is infrarenal, the patient is most likely a candidate for an endovascular stent graft repair. So here we just have some sonographic images of our endovascular stent grafts. So the graft is actually inserted into the groin via the femoral artery, and it appears echogenic with sonography. So here we can see the echogenic outline in the sagittal plane of our endovascular graft. And then here it is in transverse, so we can see our aneurysm around our little grafts. Over time, the aneurysm should decrease in size around the graft, and sonography is used to follow the diameter of the aneurysm, making sure that it's decreasing, making sure that the graft didn't migrate out of place. And then we also look at any hemodynamic abnormalities that might occur within or around the graft. Again, y'all will go into deeper detail with Miss Gray on this subject later on in the semester. There are a few types of endografts. There's a few types of leaks that can occur with endografts. And so it's a complication that can occur, and they're monitored post-placement. They usually occur from a failure of the device at placement, changes over time, or a failure to control blood flow within the aneurysm. So there's 4 different types. We'll just briefly go over each type. Type 1 is an attachment site leak, which is normally caused when the device is improperly sealed at the proximal or distal endpoints. So here, there's just not a good seal right proximally or distally, and so blood is actually leaking out. Type 2 is when you have retrograde flow through collateral branches. So these could be the lumbar branches or even the inferior mesenteric artery. So here we just have branches, and they're showing retrograde flow into that aneurysm. Type 3 is when there's flow into the aneurysm secondary to an inadequate seal between the components of the device or a tear in the fabric of the graft. So here could be a tear in the graft, and so blood is shooting out that way. Type 4 is similar to type 3, except there's flow through the fabric, except it's secondary to the porosity of the graft. So in type 3, we have a tear in the graft, and that's why it's leaking. Whereas here, the graft material in itself doesn't have a tear, it's just really porous, and the blood is just kind of seeping out of it. All right, so now we're just going to cover some other pathology. First being celiac axis compression. This is also known as median arcuate ligament compression syndrome. Most often occurs in young females. And this is just compression of the proximal celiac axis by the median arcuate ligament of the diaphragm. For this exam, we're going to evaluate inspiration and expiration when imaging the celiac axis, because the velocities will normally exceed greater than 200 centimeters per second. Our clinical findings, so when a reason for the exam would be an abdominal bruit noted with expiration, but it disappears when the patient breathes in or has inspiration. So when we're imaging, whenever the patient breathes out, so on expiration, the median arcuate ligament compresses the ventral aspect of the celiac axis. This produces an S, or like a fishhook shaped vessel, and significant stenosis. So our velocity is going to exceed 200 centimeters per second. But when the patient breathes in on inspiration, the celiac axis straightens back out and the stenosis disappears. That elevated velocity we saw on expiration is going to decrease back to its normal value of less than 200 centimeters per second. So here we have some images. So on expiration, that median arcuate ligament is going to compress that ventral aspect of the celiac axis, and we're going to have that S, or fishhook shaped vessel. So here is our expiration image. So we can see celiac axis is a little bit curved compared to here where it's a little straighter. We have that stenotic waveform and we have our high velocity. However, when the patient breathes in or does inspiration, that velocity and that waveform are going to go back to normal. So here we have more of our normal celiac axis waveform. Nutcracker syndrome is another thing that can occur with the aorta. So it actually doesn't involve the aorta itself, but it's actually the left renal vein being compressed between the SMA and the aorta. So here's our aorta here, our SMA here, and then this is our left renal vein. So the left renal vein can become engorged due to the compression of the vessel. So here it's being compressed, and then this is our engorged vessel here. This causes venous hypertension, which results in venous collaterals and retrograde flow into the adrenal and gonadal veins. And then this causes pelvic congestion syndrome in females and varicoceles in males. This is a very heavily tested subject on the registry, and so you definitely need to know that the left renal vein is being compressed between the SMA and the aorta. And then you also need to know that this can cause pelvic congestion syndrome in females and then varicoceles in males. Some symptoms of Nutcracker syndrome could be hematuria or flank pain, left flank pain. Next is chronic mesenteric ischemia. So this condition is actually very similar to our celiac axis compression. However, this condition usually takes place in older adults, whereas our celiac axis compression occurs in younger females. This condition is also not affected by respirations, and so the stenosed vessels in this condition aren't affected, or the stenosis doesn't go away with expiration or inspiration. And so this is a rare condition that presents as recurring postprandial abdominal pain and weight loss. This usually occurs in patients who have had prior abdominal surgery, which interrupted important collaterals in their abdomen. For sonographic evaluation, we're going to look at the celiac axis, the SMA, and the IMA. This is usually asymptomatic until at least 2 of the 3 major mesenteric arteries are occluded or highly stenosed. So think celiac axis, SMA, IMA. Usually the celiac axis and the SMA become occluded and highly stenosed before the IMA. And so if that happens, the IMA will become dilated. So here we have an image of chronic mesenteric ischemia. So the registry may show you this image and say something to the effect of, this patient presents with postprandial abdominal pain. This has been going on for a while, and they even had a gallbladder exam that was negative for cholelithiasis. Oh, I forgot to mention something. So with chronic mesenteric ischemia, some differential diagnosis could include abdominal malignancy, ulcerative disease, and cholelithiasis. Okay, so back to this. So we have our patient. They have postprandial abdominal pain. It's been going on for a while. They had a gallbladder scan that was negative for cholelithiasis. So the doctor decides to order an aorta exam. So you're imaging their celiac artery and you get this waveform. What would be the most likely diagnosis? And so upon looking at this image, you can see that our Doppler waveform looks very stenotic, and it's in our celiac axis. And so that would indicate chronic mesenteric ischemia. Again, the difference between this and our celiac axis compression is that this waveform does not change with inspiration or expiration. AV fistulas or AV shunts are a connection between an artery and a vein. And so these are commonly associated with angiography punctures of the common femoral vein. They're associated usually with trauma, surgery, biopsy, inflammation, cancer, or a neoplasm, or they can even be congenital. Some clinical findings include a bruit or a thrill, hypertension, cardiomegaly, or heart failure. A percutaneous renal biopsy is the most commonly known AV shunt, and it causes intrarenal AV shunts. All right, so enough about the arteries. Now we're going to move into our inferior vena cava. So the most common tumor to involve the IVC is renal cell carcinoma. This is a very common registry question, so make sure whenever you think of renal cell carcinoma, think that it will usually or most commonly involve the IVC. So that's what this picture is demonstrating here. So this patient most likely has renal cell carcinoma, and it's affecting our IVC by creating a thrombus. The IVC can be easily displaced by a liver mass, a right renal artery aneurysm, lymphadenopathy, which is just prominent or enlarged lymph nodes, a tortuous aorta, which usually means that there's an aneurysm present, or a right renal or adrenal mass, so think renal cell carcinoma. IVC filters are another common registry question. And so you definitely need to know the sonographic appearance of an IVC filter, which is demonstrated in these images here. They're used to prevent lower extremity vein thrombus from traveling up towards the heart. So this filter will actually catch that thrombus and it won't get past it. The most common type of IVC filter is a greenfield filter. This will most likely be on your registry. So whenever you think of IVC filters, think greenfield filter is the most common type, and that's usually looks like this image here. The proper location of an IVC filter is inferior to the renal vein, so infrarenal, same as an aneurysm. And this filter is placed through catheters in the femoral vein or the internal jugular vein. All right, so that brings us back to our case study. So now that y'all have been presented with this information and y'all have been kind of thinking on what is going on here and what this might be, let's get the results. So the aorta is dilated and thrombus was seen in the aneurysm. The hypotensive state of the patient and the fluid in the abdomen suggests that the aorta actually ruptured. This diagnosis was confirmed on CT here and in surgery. The condition was successfully repaired. Thank goodness. So here is just a CT of a ruptured aneurysm. So remember, if an aneurysm is ruptured, CT is the first line of defense. If we're just screening and following up an aorta aneurysm that hasn't ruptured, then sonography is usually the first line of defense. But yeah, that's all I have for y'all. If y'all have any questions, please write them down and we can go over them, and I will do my best to answer them in our review session.